Cool. So if you told me 24 years ago when I was sat in this room as a year one reg that the thing I'd be coming back to talk about would be eating disorders, I told you you were completely bonkers. So if I can learn, anyone can learn. That's the key message here. What I'd like to just talk through with you guys is this. I think the trick with eating disorders is not having a guideline. That's one of the key things I've had to learn. I can teach you the rules of chess, but that doesn't mean you can play chess. And that's the real problem, is you can read a guideline on asthma and you can save a child's life, whereas you can't read a guideline on anorexia and be any good at talking to a parent with an anorexic child. So this is just the stuff I've had to learn over the last 8 years, kind of condensed down. Just the last point, this is common, but it's also important. We will all have our own experiences in the room. And if I touch a nerve, it's important that you talk to somebody about the nerve that I've touched. Don't just sit on that, because this stuff is hard. So it's an approach. It's a way of trying to think about it as a general pediatrician, as a body doctor, not a brain doctor. How do I approach it? So if you want to take one picture of what we're going to talk about today, what I hope you'd learn, this is it. First of all, these are illnesses. They're not fad, they're not choice, they're nobody's fault. They happen, they kill children, they are a psychiatric condition with the highest rate of mortality. When you see a child getting a feed on the ward, it's like getting cefotaxime for meningococcal meningitis. It is the treatment. Okay, when you see a child arguing over a snack, it's like getting mercaptopurine for common ALL. It's the treatment. I think I didn't really know why I was seeing these kids 8 years ago. I think we have 5 jobs as body doctors, and if we don't do these 5 jobs, then we might as well get out of the room. The first is the working diagnosis, and I'm going to talk about what I mean with that. The second is to exclude other pathology. If you miss a brain tumor, hypothyroidism, celiac disease, you know, that's on us. Basically, we are body doctors, not psychiatrists. The second is to refeed them. The third is to refeed them. The fourth is to keep them safe, and I'll talk about what that means. And then the fifth is to support recovery. And we've used the word support specifically because what we're not going to do is cure them. We do not have the skills, we do not have the ability to cure them, but we have a unique skill set as general pediatricians to support recovery. The only way I can think about these illnesses is to talk about what I would call a neurometabolic approach, and I'll talk about that. We have to do better. Okay, if you look at the number of kids you talked about this morning who have functional illnesses, who've tried to kill themselves, who've tried to harm themselves, who are suffering the consequences of poor mental health in themselves or their families, we as body doctors have to do better or go and do a different job. I think this is not the job that Nick and Kishani and I trained for, but it's the one we do, right? So either get better at it or go and do something else, but we don't get to choose anymore. We don't, you know, that's not how this is. I've learned that very few decisions with eating disorders need rushing into. Okay, the eating disorders guys say if you go to Lee House, they talk about a short admission as 6 weeks. Our average length of stay is 1.1 days. It's a cognitive shift that we have to understand that actually I've got a week to make this decision, not 30 seconds. And so it might as well be the best decision I can make as part of the team. I think the other thing I've learned is to be really, really careful. A fresh, newly diagnosed, sick anorexia patient, I know how to do those. Everything else, we're winging it. The ARFIDs, the representing, the kids who come in with self-harm who are found to be underweight, but have been in the mental health system for 2 years. Those kids are really tricky, and they're the ones who are going to bite you. So I think we have to tease out who we're actually treating. And that's why I've nicked this slide off the RCPCH Eating Disorders Teaching Study Day, which is superb, and I cannot recommend it enough. I did it with Fiona last year, and it is outstandingly good. And the point is, when we use this word disordered eating. It's not semantics. It's not going, oh, I can't be bothered to make a diagnosis. It's like for us as body doctors saying, oh, it's cancer, and I'm going to give leukemia treatment to a patient with an osteosarcoma. It's just stupid to get the diagnosis wrong and then treat the wrong diagnosis. That's what they're saying, is many children will restrict their intake. Some of them have very abnormal eating behavior. Some of them are very, very obsessed with their weight and shape. And some of them have eating disorders. But unless we are open to the possibility that the diagnosis is not a diagnosable eating disorder, we're going to treat the wrong thing, and we're going to get ourselves into a hell of a pickle. And that's what I found most. We've admitted 35 kids in Winchester in the last 2 years. And I think the thing I've learned most is that that diagnostic uncertainty is crucial, but what we have to have has a working diagnosis. And I think that's really different to saying, I'm going to treat you like this until I know better. I think that's helpful. Whereas to say, oh, you've clearly got anorexia is utterly unhelpful, because that stays with them regardless of what the subsequent diagnosis is that's made by somebody more clever than me. These are diagnosable conditions. So these are the DSM-5 eating disorders. You'll see the majority of them have body shape concern, anorexia nervosa, bulimia nervosa, a lot of binge eating, and then this odd sort of OSFED sort of group. You'll also be increasingly seeing the kids with ARFID, pica, rumination disorders. And these are children who do not have a primary body shape concern as part of their diagnostic criteria. Okay, and it's really important that we understand the difference. When we had an ARFID patient on the ward 2 weeks ago at the same time as 3 anorexia nervosa patients, I could say to the parents of the ARFID girl, your prognosis is different, your treatment is different, because the things you are scared of are different. And that's really, really important. And so, sorry. So to me, that seems to be a sort of a catch-all group of these, so the really tight diagnostic criteria for anorexia nervosa, bulimia nervosa, and binge eating, whereas I think they're struggling to put all these other, these kids are purging, just pure purging or pure binge eating. I think they're struggling to know how to categorize us. And it seems to me they've sort of got this category that they've dumped them all into, as far as I can work out. For us as body doctors, we are going to see lots of ARFID, and we're going to see lots of anorexia nervosa. As body doctors, we're going to see far less of the others, because they don't come to our attention as frequently and as sick. That would be my observation. I think there's some really important stuff in this. The causation is complicated. You can't say, oh, I became anorexic because somebody in year 7 told me I was fat. That's not how this works, any more than I've got leukemia because I got a virus. I think we've got to move past that. We've got to understand that there are multiple factors feeding into this, or not feeding into it. And really what our job is to try and look at what might be driving this. A very, very wise teacher who teaches on this stuff that was done for the nurses, she said, anorexia nervosa is always a strategy. It's always doing something for the patient. And until you understand what that strategy is, you're not going to help them with that. And I'll talk more about that in a moment.
Sorry, do you mean treatment or support of anorexia nervosa is always something?
No, sorry, thank you for clarifying. My disease is doing something for me.
Yeah.
It's driving something that I need. It's giving me something. And when you come and say you're going to cure me, I will hear that you want to take that thing away from me.
Yeah.
It's absolutely crucial we understand just how messed up the thinking is in this. And so what it means is we have to, I'm more and more of the opinion that when we talk about normal, we've got to use a scientific definition. There's no such thing as a normal body shape, but there's a normal range. There's no such thing as a normal approach to food, but there's a normal range. There's no such thing as a normal fear, but there's a normal range. And I think we've got to get better as doctors at understanding and explaining, I'm really sorry, but your experience now is not within the normal range. I'll sometimes say, if I was walking down the street in Winchester High Street, I'd know you were dying of something. I just wouldn't know what. What you're experiencing is not in the normal range. And what these parents find is it creeps up on them insidiously, and suddenly they're going, oh my God, we've been sat on this. I mean, the girl on our ward at the moment, this has been brewing for 18 months. And the parents and the school and everybody are all going, how did we miss this? Well, the truth is that those tiny little incremental changes, they creep up on there, and suddenly all hell breaks loose. And for me, this is critical. I think that a mountain will only avalanche at between 35 and 40 degrees inclination. More than that, the snow never collects and it'll never avalanche. And less than that, it won't avalanche. So it's a particular kind of mountain, just like there's a genetic predisposition to eating disorders. That's just demonstrable science. There's a group of people who are more likely to have this. Why are there no anorexics in Africa? You know, that's the question that people sometimes say. Well, because it's where the mountain is. It's what the mountain is exposed to. It's the buildup of stuff that makes an avalanche more likely to happen. But the trigger for that avalanche is going to be different from the factors that cause the snow to build up on that particular mountain. And I think the psychiatrist will talk about predisposing factors, and they'll talk to protective factors, and they will talk about the things that are triggering. They understand this, and as a body doctor, that's the closest I can come to understanding what they're talking about. So as a body doctor, I need to understand this thing, the hockey stick of mortality. I have to understand, we know morbidly obese patients are more likely to die, and that their mortality ratios are higher. The same is true if you're underweight, regardless of what causes it. You are more likely to die if you're very malnourished. That's just true. What's also true is that anorexia nervosa, and most of what I'm going to talk about is anorexia nervosa, is a pathological thing. We understand this as doctors, so let's be doctors about it. It's not normal. It causes harm. It's diagnosable. You're not a bit anorexic. It is predictable, and there's a predictable serious risk of life, and it is treatable. And unless we can actually start behaving like doctors and doing our job, which is to make a diagnosis and institute an evidence-based care plan, well, we might as well pack up and go home. And so for me, I've had to try and work out what is this actually about? What is that pathology? I recognize common ALL. I understand that pathological process for ALL. I have to understand the same for AN, anorexia nervosa, because that should be what I'm good at. And so we have to understand that what you have is this neurometabolic disease. And I would urge you this evening to go home and Google the Minnesota experiment. Just watch what happens to a group of normal human beings if you starve them for 6 months. They start behaving like anorexics. So the normal human response to anorexia, to starvation and malnutrition, is to start behaving the way the kids do on the ward. It's not a mystery, it's called science. So let's do science rather than prejudice. The brain problems cause the body problems, cause the brain problems, cause the body problems. If you've got no visceral fat and you've got an ileus because you're full of ketones and not enough potassium, you are going to feel nauseous. You are going to have abdominal pain. You are going to feel foggy and unwell and incapable of thinking clearly. Doesn't matter whether you are in that ketotic state because of anorexia nervosa, renal failure, or you're on chemotherapy. It's exactly the same pathological process. What's different is the psychology of I'm not sick. And that's the key difference for me, is I'm not sick means I have no vested interest in getting better. Whereas in leukemia or renal failure, everybody wants to get better. So you get a puppy, yeah, and the puppy smells brilliant, and you're going to have this lovely family dog that's going to enrich your family life. You want to take agency, you want to have control, you don't want to be fat, you want to be healthy, you want to be beautiful, you want to be everything that we want for our children. But what if all that cool idea, all those brilliant motivations become twisted, and suddenly you've got a family dog that's biting the kids and eating the skirting board and peeing on the walls? That's what anorexia nervosa is. It's all that cool stuff, that strategy, that this is how I cope with being a teenager in 21st century Britain. But it all gets twisted and pathologized and messed up to the point at which we have to kill the dog. But the child doesn't want us to kill the dog because they still want control. They still want to look nice. They still want to have a good life. They still want to be able to have some agency over their lives in the maelstrom that is being a teenager in the 21st century. And so we come along and we poke the dog and then act like it's a big surprise when it tries to bite us. You know, when the child mouths at her mother on Friday, she's leaving the ward. Okay, that's the dog fighting back, fighting for its life. Literally, we are trying to kill the dog, and the dog is fighting back. And that's the best analogy I have in my head. And the problem is, as biology doctors, we have not understood that. And we've gone into looking after these kids with the best of intentions, but we haven't bothered learning the science, often because it was pretty poor, and we haven't really had an idea. So we've gone in with our models of how to do body doctrine. Oh, I'm just going to feed you up and you'll be fine. With my 1.1 average length of stay mindset, I'm going to fix this. I'm going to be the heroic doctor. I'm the one who can figure you out. I'm afraid that's not how mental health conditions work. What we've got to do is we've got to understand that actually the way we've approached this over the years has been terrible. And I'm slowly getting better at it, but it's been graft because it wasn't how I was raised as a pediatrician, and the people who taught me couldn't teach me this stuff. Okay, if my mother-in-law's got dementia, when my mother-in-law screams at my wife and forgets stuff that's happened, we understand that she's got dementia. And that girl will sit there and mouth obscenities to her mother. We go, oh, she's a terrible child. It must be the parent. No, it's the disease. There's a bit of their brain that is incapable at that point in their lives of functioning the way that they were raised. And until we can see past that, it's as stupid as being cross with a leukemic for having an anemia and needing a blood transfusion. We wouldn't go, oh, you bad child, you've got thrombocytopenia and bruising. How stupid. You're obviously not trying like that. We give them a platelet transfusion. It's ludicrous. But that's literally what we do with these kids. Because they sat there on the wards and they've got this ruminant thought going round and round and round and round. And these ruminant thoughts, I think it's like getting somebody to eat spiders when they're scared of spiders. And 6 times a day we sit them down and we say, right, time to eat your spider. And they go, hell no, I don't want to eat spiders. I don't like spiders. I've got no interest in understanding spiders. Yeah, just take it away. And so we get this into this, and they sit there festering with these sorts of lies going on in their head. These are the sorts of things that are ruminant, going round and round and round every second. You deserve this, it's your fault, you can control it, it's just who you are, this isn't really happening, this is normal, all that sort of stuff. If I can be 28 kilograms, I'll be happy. I'll stop then when I'm 28. All that sort of stuff. This is what's going on in the beds while we go up and do the next bit of the ward round with. And so we make deals. We go, oh, yeah, well, eat that and you can have this. Unless we're really careful, what we start doing is dealing with the devil rather than understanding what's driving the illness. And I think that's what we've got to be much, much clearer about. So when they come to us, what we've got to be thinking is, what's this narrative? What's the strategy? And then we need to do our job. Somebody needs to sit down with that child and do a proper risk assessment. The eating disorders guideline, the MEAD guideline, they're adult and pediatric now, they're one guideline. They've replaced the 2 marziplans. We actually have to work out what's the risk to this child's life now? What's the risk that they're actually going to fall over in a sweaty heap now? What are the risks of refeeding? What are the other mental health risks? What are the risks to this child's safety now from themselves, from the people that they live with, the people who are involved? Are they safeguarding? We actually need to sit down as a team and work out how sick this young person is and what the strategy is going to be to get them out of the hole that they're in, and work out if hospital is the best place for them. And that's going to be really important, because then if they need to be in hospital, we are the people who are best placed to do the first week. We are the experts. We are the right people to do that care. There's nobody more skilled than us to look after the first week of a sick anorexic's journey, because it's body meds. Okay, it's what we do. It's holistic, it's patient-centered, it's empathetic. It's what we do. So let's be good at that. We don't need to cry about the eating disorders team not coming to see them, or they're not being tier 4 beds. We don't need to cry about any of that stuff. We can do that in 2 or 3 weeks' time. For week 1, we are the experts. So let's fess up to that and go, do you know, we can do this. We can risk stratify them. We can talk to them about the fact that they're not getting enough calories. We need to get some science into their heads. Most of them haven't got a clue what a calorie is. They just think it's bad. They don't understand basic science. How many calories do you need to just sit there as a sentient human being not moving? Unless you know that, you can't have a sensible conversation with an anorexic about, okay, well, this is how much you need to be alive. This is how much you need to grow and go through puberty. This is how much you need to be able to run or do your stuff or go to school. So let's dissect out. Actually, I'm really sorry, but that's why I'm sticking you on a bed, because at 600 calories a day, you're literally eating yourself alive, let alone being able to run. So let's not have that boring conversation. Let's have the conversation about how do we get 1,200 calories into you. Because that's the thing that's going to help you. And understanding that the language of nutrition, this is no longer about food, this is no longer about weight, this is no longer about calories. This is about a dietitian coming and prescribing a meal plan that will save your life, just as much as if they were an oncologist prescribing their chemotherapy. When the dietitians come, they're not asking you to take some food, they are prescribing the life-saving prescription. And our job is to get that prescription and follow it to the letter and do what the dietitians say. They write amazing plans now. Let's read them and let's follow what they do, rather than having an opinion on something that we haven't earned the right to. You know, I've just stopped saying anything that disagrees with the dietitians. If I don't agree with the dietitian, go have a conversation as a team, glue it together, that they are writing a life-saving prescription. I wouldn't argue with an oncologist about how much mercaptopurine they want to give or methotrexate, and I'm not going to argue with a dietitian about their prescription. Our job is to glue together the team and to try and avoid killing the patient. So my simplistic way of thinking about refeeding syndrome is, at the beginning of the pandemic, you imagine a group of builders who were building a block of flats, right? And they were there, they were going to do their block of flats, they had all their bricks and concrete and all the raw materials ready to go. And then suddenly they got furloughed for a year. What happened to those raw materials? They all got nicked or degraded. So all the builders came back a year later, ready to build, and there was a bit of concrete and some bricks and stuff, and they started furiously building, and then they ran out of kit. So they then just started sabotaging buildings around them and just nicking bricks from wherever. That's what refeeding syndrome is. It's the pancreas getting given carbohydrate, thinking, hallelujah, I've got something to chew on, and going completely nuts, running out of thiamine and vitamin B and potassium and magnesium and phosphate. That's what refeeding syndrome is. And as that happens, your poor bone marrow doesn't stand a Scooby chance, and your liver and kidneys, everything potentially goes peaked on. And that's why we have to do the bloods every day and the observations, because we can avoid refeeding syndrome, not by not refeeding. We still have to give them grub. We actually have to monitor and treat and replace aggressively and proactively. Because what we're actually trying to do is we're trying to set up a team around this patient of dietitians, of clinicians, of parents, of psychiatrists, psychologists, eating disorder specialists, to actually put the team together to say, look, there's a dirty great hole in the roof. What's the first thing? What do we do next? And this is the sciencey bit, okay? So you cannot, there is no therapy in the universe that will work on a child who's starving. So let's not waste our breath talking about therapy. Let's give them some nutrition, let's re-nourish them, let's do some basic psychology, which we're all doing, and let's get them home as fast as possible, as safely as possible. That is the evidence-based, the best chance that the young person has of surviving is to get into the community with community support, getting family therapy for anorexia nervosa. That is the evidence-based scientific approach to a young person. It's not the same for adults. Adults have slightly different regime. But our job is to do the red and support the orange and make sure the green happens. And spot when the patient is slightly different from a straightforward, fresh, new anorexia nervosa admission where we've got to think slightly differently. But helping ourselves and helping the families to understand that this patient doesn't need therapy now. They need to be re-nourished and they need to learn to start challenging their anxiety, challenging their phobic behavior, challenging their lives. That's what we can do as long as we're consistent and clear. In places with a pediatrician embedded in an eating disorders team, and that's what we're going to be doing this year, you virtually have no emergency admissions. Now, this is aspirational, but if you understand what the 8 features of an ideal admission would be, you'll understand how terrible we currently are at really setting ourselves up to fail. If you don't have a good exit plan, if you don't understand where am I going to be in a week, where am I going to be in 2 weeks, where do I hope to be in 3 weeks, if you haven't really thought that through, then you're in serious trouble. You're on the back foot from the get-go, and we're trying to learn to be better at it for that reason. We're trying to get better at understanding how we make the decisions. And I think I've got about 45 minutes, so I'm not going to go into this in huge amounts of detail. But I just want you to think, when you're seeing these patients, am I doing an evidence-based, scientific, coherent, joined-up thing? Am I using the least restrictive? Am I doing something that's proportional and reasonable and necessary and has to happen now? Because if it doesn't, we'll take a breath, talk to somebody. Yeah? And I'm afraid I'm having to learn all this stuff the hard way. These are the Alpine resources that we put together. So that Sway, that QR code that sits on my phone, I give it to the parents. It's got all the links. It's got everything you need on it as a parent or as a young person or as a professional. I put it all in one place just to make my life easier. You have to be structured about our admission, and I can't go into the detail of it, but I guess my point is we wrote a pro forma for the admissions for a reason, which is that they're complicated and dull. You know, arguing with somebody about whether they can walk as far as the fish tank but not as far as the end of the desk is really dull. But if that is what it requires to safely contain their anxiety and understand where the rules are, we have to have made these plans. And I think what we have to get better at earlier, and I'm still learning, is how to put those boundaries in place and how to have those plans in place to be able to support the young people through this, because they don't know any different. So if we can contain them, then they just think, oh, that's how this works. They don't have to know that we're going, oh my God, I hope I haven't screwed this up. If we can safely contain them and go, this is how we do eating disorders here, and we will cure you, but it's going to be really brutally hard. That's a whole different message from, oh my God, let's get the eating disorders team, which is the way I've been for most of my career. We've got to be consistent. and clear, and that's the hardest thing. Anorexia is amazing, finding the little gaps between two parents, or a parent and a nurse, or one nurse and another nurse, or a nurse and a doctor, or a dietitian. It's brilliant at finding the cracks between us. And we've got to say to the parents, this will happen. Come and tell us when the cracks open up, and we will work as hard as we can to polyfiller over those cracks. But they will happen. It's not a big surprise when they. We have the ABC, antecedent behavior consequence. So we've got to change the consequences of their actions so that we can change the antecedent for next time. The consequence of my sitting down and having 2 teaspoons of my food was I felt incredibly anxious, but the world didn't stop turning. Therefore, the antecedent for my next meal is I can do 2 teaspoons. Now let's think about 3. So it's the ABC thing. And then the only thing I know about this is literally all I know about parenting. It's weird to say we should love our patients. That would be weird. But love is hard, and love is about doing the right thing because you care enough to do it rather than the easy thing. And I think these kids are having to learn the manifestation of what it's like to be utterly, brutally relentless in the face of a disease that is ghastly and life-threatening.
Sorry, can you talk about ABC again? I had a go of blank, sorry.
So the antecedent, I learned this as a registrar, but the most useful thing I ever learned as a registrar and prep 1 days or whatever they used to be called. The antecedent, what happened last time? The behavior, what did I do? The consequence, what was the outcome of that behavior? And it, you know, whether you're a toddler or a teenager or a consultant, if you want to change the antecedent for next time and therefore the behavior, you have to change the consequences. Yeah. And that's why there's consistency, but it has to be kindly and lovingly, I suppose, applied, because otherwise it just feels like we hate them, and they'll feel like we hate them. Our job as body doctors is not to get them to the top of the hill. Okay, that's the job of the eating disorders team. Our job is to get them to the first dog leg, to set the pitch high enough that it's going to get them and low enough that it's achievable, and then relentlessly support them by pedaling up that hill. That's our job. That's it. So rather than talking about this, we have to talk about that. Where are we going to be in a week's time? Where are we going to be in 2 weeks' time? Where are we going to be in 3 weeks' time? Similarly, we can't think about Maslow's hierarchy of need. We can't do all of this stuff, which they have to do, because after all, most mental health conditions are going to be wrapped up in here. Our job is to do the physiology and relentlessly do the physiology. Okay, and I think that for me is absolutely key, because what it means is all I need to talk to the parents about is the next step. I don't need to talk about the whole thing. I suspect you guys, there's a few more slides, but I suspect you all need to get on with the day you're living and do some other stuff. So I don't know, what do you think? What works better? Are you sure? Okay, well, just tell me to shut up. That first step, I think there's this really important idea of managing expectation. You know, they're not going to be in a tier 4 bed next week, and actually they don't want to be. But where do they want to be next week? And actually giving them that small germ, that seed of an idea of what's next. That's how you do a jigsaw. Is you try and get the edges and the corners. And our job is to start putting down some corner pieces, to start injecting. Do you know what? This is life-threatening. This is awful, but it is totally treatable and dealable with. But we have to be realistic, and we have to understand. And I think this is really important. So this is a picture of my shoes, looking down at my shoes from this height, which I think is how it feels to be somebody right in the middle of having anorexia nervosa, where you can't imagine what the view would be like from here, let alone that. You can't imagine. It's the same view. It's just from different heights. And these kids lose hope, and their parents lose hope. They cannot have that bigger picture. Our job is to go, there is a bigger picture here. You're going to beat this disease. You're going to go out and fall in love and get drunk and wake up on a beach somewhere in the middle. And you can't even remember, you're going to get to do all that amazing, cool stuff. But we've got to get this done first. And I know you don't feel like that, but that's the target. And actually holding on to that hope for them. And I think I talk to them about the tug of war quite a lot, because sometimes in a tug of war, you just have to hang in there. And sometimes, like in Squid Game, you actually have to give 3 paces and then stop. Sometimes you just take 1 pace, but what you don't do is drop the rope. And the parent's temptation is to be going, oh, this is just terrible. It's the worst thing in the world. We can't do this, and drop. And our job is to have enough people on this side that even if 1 or 2 of us drop the rope between us, we're still holding on. Because the anorexia never lets go. The anorexia never drops the rope. It's a 24/7 gig. And so we have to give them some ways of thinking that helps them. I always think it's one thing to want to leave Syria. It's another thing to decide you want to go to the UK. So there's push factors and there's pull factors. I don't want to be here. Where do I want to be? And our job is to keep reminding them, you don't want to be here with me. The last thing you want is some boring old man talking to you about calories. You want to be back at school with your friends doing cool stuff. So what are those push factors? What are those pull factors? We've got to be really careful. If you tell an anorexic that they look well, basically they haven't tried hard enough. If you say, gosh, you've really tried hard today, they think, no, I didn't, so I gave in. You tell them that they're, so those little cracks in the damn wall, we can just really make those cracks bigger by the language we use. It's completely counterintuitive. You see an asthmatic, oh, your chest sounds great today. Well done. We should get you home within the next couple. Oh, your weight's gone up 500 grams. That's brilliant news. We should be able to get you home next week. Whoa, okay. So the language we use, it's so counterintuitive. I think it's important that the parents and the nurses, and we often feel like one false move and we're going to die. But we're not free soloing like Alex Honnold. Actually, when he loses a grip, he dies. Whereas most rock climbers, when they lose grip, are on the end of a rope and they fall down and they flash themselves on the wall and then they have to start again. And I think that's a better way of thinking. And sometimes, the tendency to catastrophize on the wall, oh, they've had a terrible day, it can't be working. Actually, no, you're going to have ladder days and snake days. And our job is to try and get up as many ladders as we can and avoid as many snakes as we can. I like the analogy of the Rubik's Cube, because I think each kid is going to be a different combination of moves. And you kind of know the rules of a Rubik's Cube, don't you? But each solution is going to be slightly different. And you're definitely going to have days where you make all the wrong moves. But that doesn't mean that there's no solution. The solution is just as available as it was before you did all those wrong moves. I wasn't taught this at medical school, and I wish I had been. The psychological principle of habituation. So you've got a bunch of crows in a field, and you put in a scarecrow, all the crows fly away. The crows then start coming back slowly. They habituate to the scarecrow. And similarly, it's really important in terms of phobia and in terms of anxiety management. It's learning to live with anxiety and realizing that the world doesn't end. And that's what they call habituation. So you learn to live with the anxiety of putting food in your mouth. And then the world isn't quite as scary next time. That's the ABC, that habituation, that slow grinding pressure. Pushing and pushing, and it's relentless because we keep adding pressure. We don't go, oh, you had 4 mouthfuls, that's brilliant, we're cured. We go, now you need to finish your meal. Oh, really? But that concept of habituation, and that's why it's so grueling for the kids and the family and the nurses. But ultimately, we have to get them out of hospital. For me, everything in medicine comes down to cycling. So if you're mootling along in the middle of the peloton, it's actually quite easy. So it's quite, they'll find a place on the ward that's quite easy and they can just about do. If you just chuck them out the back of the peloton, they suddenly have to work really hard and they feel abandoned and dumped by the side of the road. And I think our ability to discharge plan, to ambulate, to extend out so that they still stay with us, but we don't snap the elastic. How do we actually plan for a safe discharge as quickly and efficiently? And how do we get them to the evidence-based treatment they need, i.e. community-based family therapy for Alex Universal? How do we do that safely? Because if we can do that, our job is done. And what I've seen from my experience is once you get them out of hospital, you never want them back. The second admission is always a car crash in my experience. So you really, really want to make sure that you've got that discharge as managed as possible. Now, I know some more mature units will have them in for very brief periods and whatever. I haven't yet found a way of doing that. So for me, my closing remarks to the patients when they go home is, you never want to meet me again. You are now going to get this scientifically evidence-based treatment for your disease. And you've got to work with them because you really don't want to be back here because the readmission plan has to be different. And by necessity. So those are my thoughts into this culture. I need to get on with our lives, but I don't know if that's helpful or not.
That's brilliant. You're your own profession. Oh no.
Well, it depends what I'm trying not to take that personally.
Yes, the teaching is amazing. And you know,
Yeah.
you should do this all the time.
Can you believe
Brilliant. Oh my goodness.
I'm exposed to this
I'm just
every couple of
completely
weeks, and I
mesmerised.
have goosebumps every time I listen to him talking. Exactly what I mean.
I like the honesty which you said you were not being taught, and I think we also, as a registrars, we also